kind of my passion for my job. And I'm sorry, I'm on my work computer and I keep losing connectivity. It keeps telling me I'm losing internet connection. Can you guys hear me?
Mm-hmm.
Yes.
Okay. Okay. So that's a little bit about my background. For education, I got my undergraduate degree at Miami in nursing, my bachelor's of science in nursing. I got my master's of science in nursing at Ohio State, and I'm currently working on my doctorate of nursing practice.
All right. Okay. Well, thank you. All right. So one of the things I'm thinking about when I'm listening to you, so it looks like all of you kind of work and connect up to the whole idea that you've got patients that you're addressing with healthcare needs or concerns in that. But I suspect that all of you have taken quite different paths to getting there. So, well, if you could take turns describing what your professional education looked like. What, how did you get into the, how did it, let's start with, what was your education? What did you have to do to get to where you are right now? And I guess we'll just keep the same order. Dr. Wilson can start.
All right, so I have a bachelor's degree from Miami. Say again?
Because I see you've had your mouth full, so I figured.
Oh, no, that's okay. Yeah, don't mind me. This is called The Life of a Primary Care Physician. You eat when you can. There's no such thing as a 9-to-5 job. I love it, but sometimes it means you are doing 3 things at once. So I have a bachelor's degree in chemistry with a minor in medical sociology from Miami. I was also an ROTC grad, active in a few other things on campus. And I am what's called a bent arrow. I did not get into medical school the first time. I think I had a little too much fun in college and didn't study for my MCATs either, minor details. So then I also spent 6 years in the Air Force and then went back to medical school. So I have my MD. And I did a year of research in med school, and I also did a couple years of research in residency. I started out in orthopedic surgery, and I decided, oh, that was kind of cool to fix things. It was the mid-90s, and women in orthopedics were not super common. They actually invoked a committee the year I decided to leave to research why there weren't more women and minorities in orthopedics. So then I went and did a full family medicine residency, which was 3 years. And I did all 3 years by choice. I did not have to do all 3. It gave me some advantages because I got to do some stuff I wouldn't have done otherwise. And then after that, I went into private practice. And since then, it's just been, keeping my continuing education. Something interests me, you get more training in it. And that's the advantage of family medicine, is I can kind of do anything I want to do.
Excellent. So do you have to do continuing education?
Yep.
Okay.
You've got both requirements for your board certification, and although technically board certification is not required, good luck getting jobs and getting on insurance panels if you're not board certified. So for board certification, we have requirements we have to make in terms of both educational hours and also quality measures. We are now expected to do a survey of, say, our patient panel and look at diabetes and say, okay, A1Cs or eye exams, foot exams, all these quality measures, and how are you doing? And if you're not doing well, you come up with a plan to improve it. And then for the state license, I have to do hours too. I have to have 50 hours of continuing medical education every year just to maintain my state license.
Okay. Okay. So one of our attendees asked, did you actually practice medicine in the military, or was that something that occurred after?
No, I got a master's degree in the military to be a hospital administrator, and then decided while I was doing that I wanted to go back and actually do patient care. No, the Air Force, I have 3 degrees courtesy of Uncle Sam. My undergraduate degree, because I was at ROTC scholarship, a master's degree in public administration, health services management, and then my MD. My Air Force time was in logistics, war gaming, and war planning. I like to play what-if games.
Well, that can be helpful when you're thinking about patients. And what if we did this approach? Yes. All right. I'll get back to this question a little bit. I think it's a good question to ask everybody, but I'm going to hold off on that one. All right. So Ms. Widmeyer, how did you get into genetic counseling?
Yeah, so my path was almost very similar to where it was not straightforward. I did not get there right away. I actually am jealous of a course like this because I didn't even know what genetic counseling was. I was exercise science. I think it's now kinesiology and health and zoology major at Miami, and had absolutely no idea what I wanted to do. Thought maybe physical therapy. I kind of thought about nutrition a couple times, but really graduated and went straight into research for 3 years at Cincinnati Children's, because I still had no idea what path I wanted to take, and I wanted to be sure before I went into any graduate schoolwork. And I also was getting, as part of working at Children's, they pay for coursework. So I was actually getting my master's in secondary education for biology to be a teacher, and realized that the only part I really enjoyed about it was the genetics part. So that was interesting. And I incidentally around the same time learned about the genetic counseling profession. So I shadowed a few genetic counselors while I was at work and really loved it, and kind of put together everything that I wanted in a career. Research and the science portion, the direct patient care. I really just liked every part of that combination. So it took me a while. And then I applied to the University of Cincinnati Genetic Counseling Program. It is a 2-year program. All of them are 2-year master's programs. And then when you graduate, you have to take a board's examination. And you have to be board certified and licensed. And licensure is only specific for certain states, but same thing, you need to have continuing education credits and be up to date on all of those for both the licensure and the board certification. But definitely not a straightforward path. It took some digging and asking around and Google searching on what I wanted out of profession, or what were some jobs that had high satisfaction rates. And this kind of came up in that Google search around the same time, where I was like, I have no clue what I'm doing. And I'm very, very happy in my job. And I'm glad that I found it, although it took me about 5 years to get there.
You got there. You got there.
Yeah, I did.
All right. All right. Ms. Davis, what about you? What was your professional education like?
So I knew early on when I was young, I wanted to go into medicine, and a lot of people do what some of the others have stated, and they really don't know and they change it. But for some reason I was drawn to medicine. I grew up on a farm, so I was exposed to medicine in a different aspect when I was really young. So while I was in high school, I did health occupations class. It was a 1 year of vocational school, which really just exposed me to a lot of different areas in medicine. And interestingly enough, I didn't know at the time, but what I was doing was networking. So where I did vocational school is where I've worked for the past 12 years. So the orthopedic surgeons that are currently there that I work really close with started their first year of orthopedics right out of residency while I was a senior in high school. So little did I know that I'd come back 6 years later or 8 years later and work with them full time. So when I went to Ball State, I picked athletic training with a pre-med. So I did pre-med major and athletic training. I love sports and just sports medicine in general. So that's why I went that route. I developed my kind of my plan early on in college and just set my foot towards that's what I'm going to do. Took a year off between Ball State and then worked with an orthopedic surgeon directly and did some direct patient care, some shadowing, did some, obtained some patient care hours, and then went to PA school. So when I started in PA school, it was 2 additional years. I do get asked the question a lot, why didn't I go to medical school? And at the time, I felt like it was the best fit for me. Looking back, having years of experience, would I have changed that path? Maybe, maybe not, because I absolutely love what I do now and the experience that I've had. To continue with my certification, so I'm licensed and certified as an athletic trainer, and we have to obtain continuing education every 3 years for that and to maintain that certification. And then I'm board certified as a physician assistant, so we have to retake our boards every 10 years and continuing education that's submitted every 2 years.
Okay, excellent. Thank you. All right, and Ms. New, what about your professional education? Share something with us there. And having trouble hearing you.
Can you hear me now?
Yes.
Okay, sorry, I'm having connectivity issues because I'm on my work computer. So I started at Miami and I obtained my bachelor's of science in nursing from Miami, and it is very much a generalist degree. So you can go into any area of nursing with that BSN. And so I went into ICU and ICU step down setting, learned a lot there. And then like I said, that was the stroke unit for our hospital, and many patients were coming in with strokes as the first symptom that they had diabetes. So that's where I really developed this passion for diabetes education. I moved to a trauma unit from ICU step down just for a change of pace a little bit, a change of scenery. Learned a lot there, and that's when I went back to school for 2 years to obtain my Master's of Science in Nursing with a family nurse practitioner focus. The master's degrees in nursing are more a focused degree, so you can become a nurse practitioner, family practice nurse practitioner, where you can see a wide array of patients, and most commonly you will practice in the primary care setting. You can become a neonatal nurse practitioner, a psychiatric nurse practitioner. There's many different paths you can go with your Master's of Science in Nursing, but I chose family because I wanted to really focus on diabetes management, which occurs mainly in primary care. And so I obtained my certification as a certified diabetes educator, and I'm also certified as a family nurse practitioner and licensed through the Ohio Board of Nursing in the state of Ohio.
One thing that seems to be in common with all of these careers is that it's lifelong education. It's not like you learn so much and now you just go do, but rather you constantly learn more and more, which is kind of like what I do, but not necessarily in the healthcare profession. But still, it's I think you reach a certain level, and you just want to keep learning, and you just want to keep adding into it. And all of these careers sound like that there's certainly that kind of opportunity. All right. So some of you have kind of addressed this a little bit, but I know many of the students in attendance here are kind of thinking, how do I decide? How do I decide which path I want to pursue? And so what types of things motivated you to select the path that you decided on? You know, Dr. Wilson has a rather convoluted path. If you let her, she gave us some of this, but really thinking about things that motivated you to choose the path that you did, and see what you can share with us on that.
Well, I actually decided I wanted to be a doctor somewhere around 5th or 6th grade, and it started out, my mother was working on her PhD in education, and a friend of ours was getting her bachelor's degree in nursing. And we had some other friends that were nurses. And I said, oh, I'm going to be a nurse, but I'm going to get my PhD. And somebody, I don't know if it was my mother, my grandmother, somebody kind of made a wisecrack, well, then just go be a doctor. And I kind of said, okay. And was the end of it. I mean, all through undergrad, all through high school and everything, I wanted to go into medicine. Not getting into medical school was actually the best thing that could have happened to me, but at the time it was rather devastating. But it didn't change the fact that I still wanted to be in healthcare. I picked up the master's degree in hospital administration because I realized that I do have skills in the what if games, in operations, and thinking through those kinds of problems and solving those kinds of problems. But in doing that, I had the opportunity to actually do an internship at our base hospital. My commander and the hospital commander agreed to let me do it, and so I switched jobs for a few months. And I loved what I was doing, but I also realized, no, I really wanted patient care. I can be the administrator, but it was patient care that I really wanted to do. So it was just basically a matter of getting myself back from overseas. And, you know, I went back and retook my MCATs, applied to med school and got in, and, you know, never looked back. I initially thought orthopedics as opposed to family medicine, which was actually a switch. I did an honors paper on family medicine as a specialty when I was an undergrad, because it's only been an official boarded specialty since the early 70s. So it was relatively new compared to, like, say, surgery. And I thought it was really great because you could do everything, cradle to grave. It was relationships with people. It was everything. And then I got kind of what I call my Top Gun moment. You don't become an orthopedic surgeon if you're not top of your class. And you don't get to fly fighters in the Air Force if you're not top of your undergraduate pilot training. So it was kind of an ego thing to go do ortho. And plus it was also an interest in sports medicine. I had an injury and it was kind of cool how you fixed it. And that was kind of cool, got to move on. But really coming back to family medicine was the right thing. And I love what I do. And I love the variety that it's given me and the opportunity to basically reinvent myself as my lifestyle or my family needs or my personal wishes have dictated.
Okay. All right. All right. And Ms. Widmeyer,
Yeah.
why
Go
why
ahead.
genetic counseling? Because some of this you've already kind of alluded to, but
Yeah.
sometimes it just bring new focus to this particular aspect. Because yes, our students here are they're seeing an incredible array of healthcare related careers, and I know that you had some. You described that you had some of those. Which do I want to do? Do I want to go nutrition? Do I want to go? I'm interested in sports medicine. I'm interested in this, and so.
Yeah, I think the most important thing for me was the internship, the shadowing experience is really having those opportunities to see what the day-to-day life was. I mean, before I went to undergrad, I thought I wanted to be a pharmacist. And I went and I shadowed a couple of pharmacists in different settings. And, that was one of my options. But I think really seeing what people do day to day, because I mean, that is going to be your life. And what you read or about online, it's not really the day-to-day work that people do sometimes. So I think really getting that experience has helped me. And I think most people, I mean, if you're interested in a field like this, they come at it from either a psychology or pre-med genetics backgrounds. Those are probably the most common undergraduate degrees. There is a lot of psychology background for this career because when we are giving diagnoses to families, it comes along with a lot of psychosocial counseling, psychosocial assessment, trying to provide counseling and testing in a way that is meaningful for families and that meets with their expectations and their wants for themselves or their child. So for me, that kind of put everything together in the constant changing field. I mean, even when I graduated, genetic testing has exploded in the past 9 years. And we can do so much more now than when I graduated. So I think for me, it was the versatility of the profession that I can work in oncology or cardiology, and you can kind of switch back and forth. I really love the inpatient side because I get to work with all of those providers. So I work on a daily basis with the neurology team or with the cardiology team. But you have to really love education, providing education, and really trying to bring it down into a way people can understand, and psychology and empathy, psychosocial assessment, stuff like that. So I think the key here is experience. You need to see what people do if you really want help in deciding what's the right career for you.
Yeah, coming out of high school, it's really tough to know.
Yeah.
I think I have a vague interest in something somewhere, and then trying to find that path is really important. All right, Ms. Davis, what about your path?
Well,
How'd you get from the farm to the PA? Yeah.
so like I said, when I was in high school, and I tell every student that ever rotates through with me is start your networking as young as high school or even college. And what I mean by that is even if it's you cross paths with somebody that later on you eventually use as a reference or have conversation with or do some shadowing hours with, there will be people that stand out to you that you may cross paths with again, or they can network with you to maybe do a rotation somewhere else in another city because they've had a med school or a PA school classmate that's somewhere else. I did a lot of that. I started just kind of keeping notes of shadowed this person, shadowed that person, talked to this person. I think it's really important when you're undecided or you're trying to decide what you want to do. Go and shadow as many people as you can. If pharmacy is an interest, shadow it. Genetic counseling or being a medical doctor, a PA, an NP, or if you don't really have a full understanding of what they do on a day-to-day basis, shadow them and use it more of as a process of elimination. I really like this. I want to spend more time with this profession. I don't like that. Because really, even if you go to med school or PA school or NP or anything that you do, there's still so many specialties within that profession that you're going to end up going, I do like this and I don't like that. I don't like urology, but I like spine surgery or whatever the case may be. I've been very fortunate to have worked in, I've spent a few years in the ER, a few years in spine surgery, several years in orthopedic surgery, some time in family medicine, a year in rheumatology. If you were to tell me I could get all of that experience and go back to PA school, I'd do it in a heartbeat. But if you were to tell me I would go into another career and only be in one specific area, you know, I would say, okay, would I like that or not like that? And so the best advice I could say, and what I did myself and how I got to where I'm at now, is by networking, shadowing, process of elimination, things that I really loved, and then applying that to what is important for you, what's important for your work-life balance. And for me, I knew that I wanted to be a mom, and I knew that I wanted to have a family. And so I wanted a career where I wasn't specifically on call all the time, or I'm gone every weekend. And I've gotten to the point where in my career, I did work 60 and 70 hours a week early on before I had kids, and I took call, and I was in the ER at midnight. And I loved every minute of it because I was developing, you know, my profession, and again, I was a new PA right out of school. And so I didn't care to be in the ER at midnight. Now with 4 kids, I do care to be in the ER at midnight when I've got to get back up and take a kid to school or whatever. So I think the best advice I could give, and just my career path has just evolved by the steps that I've taken to really enjoy the things that I love the most and network with those people. And after years of experience, say, I really like this, or I really don't like that, or this is what I want out of a job.
Okay, excellent. All right. And Ms. New, do you have something that you want to add about how you managed to select your career path?
Well, I would say it started during my undergraduate education at Miami. We offer our students many different opportunities to gain experience on general med-surg units, on higher levels of acuity units, on pediatric units. And so you can kind of get a feel for where you want to go once you graduate. For me, like I said, I discovered that I really liked that patient relationship where I could educate them on whatever process was going on. So that's why I kind of went in the primary care setting. I like the primary care setting because you can develop a relationship with the patient. You see them every 3 months or so, and that's if they're doing well. Especially our diabetics, we like to monitor them every 3 months. So you get to know them very well, versus in the hospital or working bedside, you see them for that acute process, and then you may never see them again. So that is one of my favorite parts of my job, is that I get to know my patients very well, their families very well, and I find that very fulfilling. And you get to teach them, and they look to you for advice on how to manage their health conditions. And so I find that piece very fulfilling about being in family practice.
Okay. All right. I want to turn over, head to some of the student questions. We've got a few of them that are coming in here now. And so we'll start off with the question, what advice would you give to your younger self as a freshman or first-year undergraduate student? What would you tell yourself?
Say, don't fret the future. You know, going into a healthcare field, whether it's going to be getting your NP, your PA, an MDDO, a master's in a science field, you're making potentially they are big decisions when you're young, and frankly, developmentally, our brains aren't even capable much of thinking past Friday night until we're probably 21 or 22. So don't be afraid to explore. I limited myself a little bit as an undergrad because I was so afraid of my GPA. It'll all come out in the wash in the end. You know, I didn't get into medical school right away. Plenty of interviews. There was just lots of little things. I should have done a few more things as an undergrad and had a little more fun. I mean, I did have fun, but there were some things it's not the only chance I would have had, but it would have been nice to have done some things younger. But I would also emphasize, especially what Carrie said, one thing that's really good at Miami now with the Mallory-Wilson Center is the ability to do the shadowing. Much more plugged in, much more ability to reach out and check out new things. 40 plus years ago, it wasn't quite as well formalized that we could do those shadow opportunities. And if you didn't know a doctor or know somebody who knew a doctor, it was much more limited. So I think that that shadowing, if you're not sure what you want to do, is important. And even if you know you want to do PA, NP, some sort of science, but patient related, you still want to explore within that, because I've had students that, oh, they think they want to be a cardiologist, and they spend a week with me and they're going, wow, didn't know you could do all that stuff. So that's that exposure and experience. So, but enjoy your undergrad. You know, spending Friday night at home studying is probably not going to ultimately make that much difference in where you end up.
Okay. All right. Ms. Woodmeyer, what would you tell your younger self?
Yeah, I would say, you know, definitely utilize your resources. I don't think I used them enough when I was struggling with figuring out what I wanted to do in a career. I think a simple conversation with some of my professors about what my interests are might have been helpful. So I think outside of shadowing, just use the resources that you have. Talk with other people. You know, they might introduce you to a new career that you never heard about. Like I first heard about this through a speech pathologist. So yeah, network, kind of mimicking what everyone's been saying, shadow, talk with a past graduate if they're available who's in a career. Just try to make those connections.
All right. Ms. Davis?
I agree with what they both said as well, but you know, enjoy your undergrad for sure. These are years you can't get back. I mean, don't enjoy it too much, but enjoy it. You know, make friendships. These are friendships that, you know, some of those close friends that are going through the same types of program that you're going through, or even if they don't go on to med school with you or PA school with you, or some of my closest friends are from college that I, you know, was in the same undergrad with. So continue to just enjoy that time, and yeah, don't make irrational decisions at such a young age.
Okay. All right. All right. Ms. Newt?
I'll agree with the other panelists as well. I always tell my nursing students, if they want to get that A+, and if they don't get that A+, they feel like they are a total failure, and that is so not the case. You need these experiences that you're going to gain during your undergraduate years, so definitely take advantage of that. You don't have to have that A+ in every class to get into grad school, you know, so just do your best, but really try to enjoy these years.
And sorry to add to that, just one more thing. My internship that I had while at Miami with Cincinnati Children's, I did an internship here. That got me my first job. So like, I cannot stress enough doing things like that, way more than my grades. And in fact, that I went to Miami University was a plus, but that internship is what got me my first step in.
All right. We're getting a lot of questions here. At this point, what I want to do, rather than doing the rotation going through, I'm gonna pose the questions, and I'm going to let the panelists jump in, those that want to contribute an answer. So we've got two of them that are very similar. Let me read them both, and then I'll turn it over to the panel. So one is, how would you describe the flexibility you have in your profession, both in variety in your career and your work-life balance in general? And the other one is, how do you balance work in the medical field with life outside of work, your family life? Do some paths allow for more flexibility than others in this regard? So, panelists?
I'd like to hear what Gary and Tricia have to say about that, because I do think as a PA or an NP, you have a little more flexibility, because for better or for worse, there's an element of shift work, at least when you first start out, 3 days on, 2 days off, whatever. You know, medicine, especially, you know, medical school and even residency with all the changes, I mean, it's 3 to 5 years of 60+ hours. There is overnight in the hospital. It can be done, but you have to be able to plan ahead. And you may have to decide, delay something a year or two.
Okay.
I think I'll kind of agree with that. I agree with that a lot. For me, you know, when you're working with a collaborative physician, especially, so in my particular position right now, I run my own schedule. I come in whenever my patients start. I leave whenever I'm done with my particular patients. I don't need to wait around the doc. He doesn't wait around on me. A lot of times I'm there beyond that because I'm answering extra patient phone calls or following up things. And I like to, I very much connected with my patients, so I don't always have the nurses call patients back, especially if it's a grim diagnosis or I need to talk to patients about certain things. And so I tend to spend a little bit more time there than the doctor does, but I have been in the specific specialties where my schedule's at the discretion of the doctor. So when I was in spine surgery, when we're in surgery, we're in surgery. And so we're leaving whenever I'm leaving when he's done. And when we're on orthopedic call, I'm there when the doc's there. And so my schedule really wasn't as flexible from that aspect, unless it was like on a clinic day. So, you know, it just depends on the specialty that we're in. I have a nice setup right now, which in the specialty that I'm in. And I particularly have stayed in that area because it allows me for that nice work-life balance where I can do extra things right now with my children. They're at the ages that they really need mom at home at certain times. And I know that in the next few years, that's going to be gone. So I take advantage of that.
Okay. Okay.
I think it does definitely depend on the specialty. In primary care, you know, typically you're working Monday through Friday, weekends are off, holidays are off. We do take call once a month. You take call for a whole week. Where my particular practice, and this would be dependent on your practice, call is very light. I may have 10 calls for the whole week when I do take calls. So it's very light. So primary care in particular, I think, provides you that best work-life balance because the schedule is more conducive to that versus the hospital, which is a 24/7 operation.
Okay.
I think a lot you have to look at what your support network is too.
Mm-hmm.
You know, work-life balance is not all on you. You know, because I was married when I went back to medical school and we wanted a child. I mean, we were planning pregnancy and research years so that I wasn't doing crazy clinical time. Same thing when we had hoped for a second one, things didn't work, but again, it was planned as part of taking an additional research year, things to, you know, that where it was a little less of a crazy schedule, but you have to have the support. My husband, it was a challenge when I was in orthopedics because my daughter was 2.5 years old and my husband was a cop. He was working nights. I'm on call every third night. We had to make sure we had childcare, and we didn't just need one layer of childcare, we needed 3, because what if the one was sick or called off? So part of being able to balance your work life, have a family, do other activities, is you have to plan. I think there's an element, depending on your specialty, of losing a certain element of spontaneity. You know, you just can't decide on Friday night, you know, you're going to go do something, because you've got to make sure your patients are covered. And you then have to make sure that, you know, what's going on with your family. It can very much be done. I mean, in my residency, every married female and every male that was married the year behind me in residency, all of them had a baby in residency. We were joking, don't drink the water.
Yeah, I have just an 8 to 5 job Monday through Friday. I'm never on call. I don't do weekends, so I don't have that. I have a pretty good work-life balance that I don't have to struggle with, but I work with many residents who do, and they're the ones who are on the nights and weekends. And so I just regroup with them in the morning.
All right. So, all right. Burnout is always an issue. Okay. In healthcare fields, people in healthcare fields can experience burnout. Have any of you experienced elements of burnout? What do you do to avoid burnout? When do you start thinking about learning how to cope with things like burnout? So, who has a thought about that?
I guess I can go first. I mean, I think with any job you can experience burnout. I think it's always important to take care of yourself and to just reassess everything that you're doing and talk with others when you're experiencing it. So, and kind of also as part of answering someone else's very specific question to me, so the NICU is the neonatal intensive care unit, and I also work in the pediatric intensive care unit and the cardiac intensive care unit. So this is all inpatients. And it can get very taxing. I work with families that are in acute distress. their child is sick. I have seen plenty of babies die that I have developed relationships with families from really rare and terrible genetic conditions. So yeah, it can get taxing, you can get burnout. And the way that we take care of it is that, you know, we talk with each other within our profession, and we, you know, seek help when we have really difficult cases. I mean, it's just something that's in the nature of being involved with clinical patients. You're going to have some of these really difficult things. So it's always a struggle. I think no matter what job you have, you're going to experience that, unfortunately.
Yeah. Just to follow up with you, because it kind of relates to what you just said. One of the students asks, says that you've worked in the NICU as a genetic counselor. Is that part of your hospital's pediatric genetic counseling program, or does the NICU identify as a separate program?
The NICU is different. So I work on inpatients alone, and we also have our outpatient clinic. So these are patients that are not critically ill. They are not admitted into our hospital and come for your just general appointments. So we have pediatric outpatient appointments in many different areas: general genetics, cardiogenetics, neurogenetics, ophthalmology. So we have a lot of different specialty clinics. So they are different entities. So I work with admitted critically ill patients versus a lot of my colleagues work with you know, they could see a child who has developmental delay and autistic-like features, seizures, things that they might see on the outpatient side versus what I see. So they are separate.
Okay. All right. So following up on burnout, there's another question here about how one deals with disappointments in your career. So because I think those can be interrelated. I'm guessing. I'm not. I just help pre-meds. I don't actually do any healthcare. So anybody want to weigh in on that? Disappointments, how do you deal with that? How do you cope with that? Because it's certainly not every patient story has a happy ending, right?
I'll comment on it. So I'll make a little comment on the burnout. I don't know that so much for me it's burnout as much as, you know, we all have, and every one of us could tell you some stories. There's probably some specific patients that really stand out to us, and you lose a patient or you grieve with a family and you empathize with them. And sometimes you walk out of the office and you're like, why am I doing what I'm doing? Or you're so emotionally taxed that you have to recover and regroup. And so sometimes I think, not that you're questioning why you started this career, but did I do everything that I could do? You know, you feel bad for the patient. I mean, I've had a few cases where, you know, I've had to, actually several cases where you're giving a very grim diagnosis to the family. And so do you hold it together? Do you cry with the family? Do you cry before you go in? So, you know, that's just real life. But being compassionate. So I wouldn't call that burnout, but just some, you know, frustrations in your career, or just some hard times. I think my biggest frustration is with administration. So administration and clinical aspect of medicine don't always go hand in hand.
Yeah.
And so you're trying to get something approved or something from a clinical aspect that you feel is beneficial, but administration doesn't quite understand, and probably way more in detail than what they care to hear about. But I think that's probably my biggest frustration.
Yeah. Or insurance companies. That's probably, I've traded one pain. You know, I don't have to prior authorize stuff the way I used to. If I want an MRI, the patient doesn't have to do 8 weeks of physical therapy first. I just order it if I think there's clinical grounds. So that's nice. But the flip side is I have this wonderfully archaic electronic medical record. And I was an early adopter, so I'm not anti, but this system is still DOS based, you know, C : yeah. So yeah, administrative frustrations are there. I think with the burnout, you have to understand, first of all, what burnout is. Burnout is not exhaustion. Burnout is not depression. Burnout is total and complete feeling like you have no control. You are depressed. You are exhausted. It's multifactorial. I think most physicians, if they're honest, are going to admit at some point in time during residency, either because of exhaustion or other things, they probably were a moment of depression. You know, a lot of residents end up on antidepressants in residency. It's reality. but that's not burnout. Burnout is really this total feeling that you're not in control. It's why are you doing it? It's so much more. You prevent it by identifying things that are important to you and maintaining them in your life. My surgical internship year sucked. I think I got to church twice. I am not a gotta be there every Sunday kind of Christian, but going twice, like Easter and Christmas, is also not me. And even during COVID, not being able to go to church has driven me crazy. That's just something that I need to help me keep more balanced and grounded. And disappointment, you got to define disappointment. Disappointment, the patient that you worked really hard to help files a complaint against you. You know, disappointment because you didn't get a job, you didn't get a residency program, you weren't chosen as chief resident. You have to define the disappointment. And I think it's hard for a lot of us who go into healthcare professions because we have an element of type A, OCD, always top of our class. I mean, how many of us were top of our high school class? And the first time we got a B in college, we absolutely flipped. And you have to define the disappointment and start realizing that, you know what, congratulations, it's life. And it's hard. Everybody has to learn their coping skills, but you need to learn it now. Burnout in healthcare starts in the undergrad years. It does not start in residency. It does not start when you're in practice. It starts as an undergrad when you do spend Friday night studying and not going out with your friends.
I will second that notion, Dr. Wilson, about the insurance companies being one of your biggest frustrations. In the private sector here, we are constantly doing prior authorizations for medications. Many times the insurance companies will dictate what we can prescribe regarding, basically because they won't pay for a medication until you've tried X, Y, and Z, and the patient's failed X, Y, and Z, even though you knew where you needed to start in the first place. So the patient has to go through this, you're going through this, and that is really frustrating. And then I think with burnout especially, and I'll just echo what the others have said, is just you try to really engage in things that you enjoy. Don't lose those little pieces of yourself to work, which can become very overwhelming and all-consuming at times in the healthcare profession.
Hey, all right. I'm going to try to field this next question, and then I can hopefully get backed up by the panelists here. The student asks, is pre-med required if the end goal is to become a lab-based medical researcher? And I would say no. Okay. What's required is some depth in biologies and biochemistries, some lab experience. But the other question is, what, in terms of medical research, do you want to be directing a lab where you are conducting studies? You may be working with physicians. You may have physicians on your team. It could. I have known physicians that run research labs. Medical research labs. I have known PhDs that run medical research labs, but there's a lot of networking and connectivity that goes on there. And so at the level of medical research, we're really thinking about teams of academics and physicians that are working together in these areas. So anybody want to add into that or counter me?
I would wholeheartedly agree. If your goal is you want to do some type of biomedical, bioengineering type research, do that. You're going to be taking the same courses as a pre-med student, but you don't, it's a different focus. It's a different focus in your head, if nothing else. Yeah. You do not need to be pre-med if this is what you want to do. You want to work on oncology genes, you want to work on, genetics, do that. The pre-med's nice, but it's not going to gain you anything for where you want to go.
Okay. Let's talk a little bit about impact of COVID-19. Someone's interested in doing shadowing, but a lot of that is shut down because of our current outbreak. So they're asking, how do you gain shadowing opportunities now?
Virtually.
Virtually, yes. I will tell you that I think some opportunities are starting to open up again. Now we know a lot more. When they shut everything down, we didn't know what we were dealing with. We didn't know what we had to do to prevent it. We know a lot more about it right now. And so I've seen some of this now beginning to look at, yes, the medical profession has recognized that students need those shadowing opportunities. The virtual stuff is better than nothing, but it's not nearly as good as in person. And we can keep people safe. We know what has to happen in the hospitals. That we know what situations to keep students away from. We don't put them in an ER where we don't know who's coming in and what they have. But so have some faith that it's going to get better. Okay.
And Kimmy and Carrie and Tricia, what are you guys seeing where each of your individual places are at? Because I know for me in the VA, I've got a resident with me, and we can have students in. I've got an undergrad who wants to do a PA shadow, as a matter of fact, with one of our PAs. And I think at this point in time, it is site dependent. There's no hard and fast.
Yes, I agree. That's what I'm seeing. I know we are still allowing students to go into the hospital setting for clinicals. We just can't let students go into any isolation rooms to try to conserve the PPE. And then right now I have a student that I'm precepting in the primary care setting, and Premier, which is the health network I work for, they're still allowing students to come into primary care. We just, of course, try not to expose them to patients who are where we're suspicious for COVID.
Right.
Mm-hmm.
Yeah, our profession, we used to allow shadowers. Right now, of course, it's a little more difficult. We still have pre-med students, medical students, residents, fellows, genetic counseling students that are with us. So we have too many rotators that we have to figure out things for, but we have different virtual genetic counseling information sessions. So like if you go to University of Cincinnati's genetic counseling program website, there are several opportunities to speak with genetic counselors, learn about what they do, and they do have online case examples. So we had a bunch of recordings of possible case scenarios, so you can kind of see what we do on our virtual platform.
Our hospital is still limiting, with the exception of the students that they already had contracts with. So we have some med students that are rotating through that were contracted before COVID hit. They've really limited some of our students, but within the next few months, they're reevaluating that. It's interesting that Dr. Wilson said that I just proposed virtual shadowing with our administration recently, at least to get some kind of patient hours. I will say before COVID hit, requirements to shadow and or to watch surgeries in the hospital where immunizations had to be up to date, a current TB and a current flu vaccine, and all that had to be, they requested documentation of all of that.
Yep.
And you had to have your HIPAA, HIPAA training.
But yes.
HIPAA training, yep. All right. As long as we're on the topic of COVID-19, how has this impacted your career? How are what you do adapting to this to the pandemic? It's a huge stressor on our system, as well as a stressor on individuals. So that, and what changes are you expecting to see in the medical fields as because of this, as we go into the future? We're not going to be done with this anytime soon.
No.
Definitely increased telemedicine. So our hospital was just kind of getting their foot in the door of telemedicine when COVID hit. With us being a specialty, we very much limited our patient exposure, but didn't completely shut down clinic. I started doing telemedicine right away, especially for patients who are 60s, 70s, 80s, who needed follow-ups for prescriptions and that kind of thing that we really didn't want out and about in the community. So we started doing a lot of virtual visits, some via telephone, a lot via just either FaceTime or virtual calls where we could physically see the patient. And then our hospital, of course, like all the other hospitals in the country, shut down surgery. So we limited any kind of procedure that we did until they let us start those again.
Hey, Carrie, with you doing orthopedic stuff, how have you handled the virtual? Because the VA has been trying to do a lot more virtual medicine for 2 years. And when we were told to shut down on March 16th, we were literally told at 8:45 in the morning to flip everybody to virtual.
Sure.
And it's a whole issue. You know, I've got 80-year-olds that love the computer, and I've got 30-year-olds that are like, I'm on an all-day doc. I am not doing my doctor's appointment with a computer.
Sure.
But, you know, but like orthopedics, you know, how do you examine a shoulder if somebody comes in and then you think it's a rotator cuff? I mean, that's my issue with this virtual stuff.
You know, if I can physically see them, I can have them, you know, talk them through forward flexing their arm, extending their arm. If they're up here like this and they're reaching behind their head, so I'm kind of checking external rotation, internal rotation. And if they can't do that, I'm already formulating that differential diagnosis. Do I think it's labrum? Do I think it's rotator cuff? Do I think it's bursa? So, and just by asking all of those questions, what kind of things bother you? What limits you? Have you had an injury, et cetera, then I'm trying to formulate, do I think, you know, where do I think their pain's coming from? Or is it coming from cervical? And just watching them do range of motion. So already before I even put my hands on them, I'm kind of in my head thinking it's either X, Y, or Z, and I don't think it's A, B, or C. That's how I do it. Obviously, putting your hands on them, doing some special tests, that's the most benefit. But, and then of course you can't do any injections or anything like that over the phone or over the computer. But at least it kind of gives me an idea of what I think's going on.
It can help you predict what your next step would be.
Yeah, absolutely. And, you know, if I can physically see them and they can see me, I can walk them through, you know, because physical therapy shut down too. I can walk them through, I can stand back and show them some exercises that may help. So, okay, for the next 6 weeks, these are the things that the therapist would teach you. These are the things I want you to do. And then if it's a post-op patient, I would have them pull their sleeve down so I can see their shoulder, or I want to see their knee, or we particularly do a lot of spinal cord stimulation. So I've had 85-year-old patients send me screenshots of the backside of their husband's, you know, I only need to see the incision. I don't need to see anything else, but I'd get the whole screenshot. So, you know, I think if you're just really patient with the patients, but I agree. I mean, you'd have a 30-year-old that doesn't want to download the app or whatever, but you have 80-some-year-old that's willing to. I think it also goes along with how much do they want to invest in their own care. So explaining to them, hey, we really want to help you. We're limited to, we hate that we can't see you in the office, but here's what our options are. If you want us to do this virtually, we really need to be able to see you and connect with you. And there is a degree of you know, having that personal connection with them by being able to physically see them, and, or, you know, you can assess their cognition, you can assess their, you know, a little bit of their range of motion and that type of thing if you can see them.
Did you guys have problems with your HIPAA? Because that's the biggest issue that I've encountered. The VA they have their own program, but the platform was not up to handling the thousands a day because the VA operates off a single server farm. It's not at each facility. So we aren't allowed to use Zoom. We're not allowed to use FaceTime. None of those things. We finally got permission for Doximity, but that means using my own personal cell phone.
Sure.
How did you guys handle the HIPAA issues with that?
We use Cerner as our EMR, and so there's a piece to that has an electronic medical system, or not electronic medical, a virtual system to it. So it was all new to me. We have never done it before, but they had to download some things to our iPads and our MacBooks so that we could connect with patients, and then they could track that. So they were still scheduled as if they were being seen in the office, and so I was able to connect to them via an app that they downloaded, which was all then HIPAA compliant.
We need to talk later about Cerner because the VA is going to Cerner.
What do they have now?
Their own program they wrote 25 years ago, and I'm not kidding.
Okay.
They were the first completely integrated system. They literally took their paper processes and computerized it.
I like Epic better. TriHealth has Epic.
I used Epic. I've used most of them. Epic, yeah, and they were going with Epic and they decided not to. That'll be part of my talk on the VA in November, the joys of doing some of this stuff in the government. But yeah, HIPAA has been an issue. I think I agree with Carrie that that's going to be the biggest thing is they're all trying to do a lot more virtual, and I think it's a challenge. I've got patients that, you know, they're stable. I got a clue what's going on, and because my panel is new to me, so some of these patients I don't know, and that makes it more challenging. But the patients that I've become familiar with, a phone call tells me all I need to know if they're really doing good. New patients, new problems, it's a challenge. I have a patient who's discharged from the hospital for a CHF or COPD exacerbation, pretty hard to really know what their breathing's like when all I'm seeing is about, collarbone up, and they're being very quiet and very still. That's not like having to walk down the hall to my office, that I really realize they're not doing well. So I think that's the biggest challenge going forward, is balancing virtual and some of the gee whiz. This is cool. It's nice. It's simple. For patients, it means no copays. There's financial issues versus what's still good medicine.
Yeah, I'd say our field is a little different. There are plenty of us that actually work remotely, and plenty of positions that are remotely because of what we do. We don't have to put hands on patients. So we have had that kind of set in place for a while, and we actually had a lot of telemedicine in the genetics department at Cincinnati Children's prior. So luckily we were set up and we use a system called Teams that's through Epic. So that has been really awesome for us. It's about 40% of our patients right now, and actually has been very helpful to outreach to some of our patients that have a difficult time coming to multiple appointments. I mean, some of our patients have about 8 or 9 different appointments, and we're definitely not the most important one when they have a heart defect and they have GI anomalies and they have to go see all these people. So it actually has helped us outreach to patients that have been pretty frequent no-shows, and has been a really nice service for our patients. So I think it's almost forced us to expand something that probably should have been available to our patients. So I really enjoyed the change. Most of our team has, and some of us work from home. The people on the outpatient side work from home a couple of days a week and do everything by telemed.
We're doing a lot of e-visits as well in our practice, but I think too, COVID's really changed the design and flow of the office as well. Patients, when they come in, are now screened with the questionnaire. Of course, we take their temperature and all of that. And we've also now separated our sick rooms from our well rooms. So if someone's just coming in for basic refills of, their maintenance medications for their diabetes, hypertension, whatever chronic disease we're managing, they go to a separate part of the office versus, we've separated now that only sick people will go to the sick rooms.
Yeah, we're all adapting, aren't we? All right, more student questions here. Let's see. Scrolling through the list, and gap years. All right. The question is, would you consider a gap year before applying? Is it worth it? I know many students take the opportunity to gain more hands-on experience and buttress their extracurriculars, but is it a difficult transition to get back into your study habits if you're not studying for a year and then all of a sudden going to medical school, you have to learn how to study all again, or what? How does that work? What's your experience there? Somebody who took 6 years off.
Well, yeah, my master's degree was literally writing a research paper for 6 weeks, but it wasn't studying per se. I don't know. I didn't think it was that hard because it's what I wanted to be doing. I mean, it wasn't that hard. I think a gap year depends on why you're taking it. If you're taking it because you're concerned and talking with, Taylin, other advisors, that maybe your application isn't as strong as it could be for medical school. Maybe you're not as competitive. Then that gap year could be a chance to enhance that. Or are you taking the gap year because you're just done with school? You want to go on, but man, you're done with biochemistry and organic chemistry, and you just want a break. You want to go live life, and, travel the world, literally in some cases. I think it's the purpose. What's your purpose? Because at least from a medical school standpoint, when you go back and reapply, they're going to want to know what you did and why you did it. So you have to be able to say, I did this, man. I went and spent, 6 weeks in Europe doing bicycles. And then I went down and I spent 6 weeks in Egypt. And how did that contribute to where you're at now? And how do you see that having shaped you? You don't do things specifically for the future, but yet it's all going to come into play because everything you do makes you who you are. So, the gap year is just, why are you doing it? It's nothing wrong with it. It might mean the difference between getting into Harvard versus getting into Case or a second-tier medical school. If you're real concerned about the school you go to, don't take a gap year. But if you want to be a doctor and you just want to be a well-rounded person, take the gap year if you want.
Some people might want to recover financially a little bit too.
That too.
Yeah.
Yeah.
So there's a lot of reasons. Yeah. Do something meaningful in a gap year.
I
That-
will
that-
say that I agree with everything that Dr. Wilson said. I will say that it's very difficult from not making anything in your undergrad or maybe $5,000 a year in, you know, because you're working very minimal hours, to making 25,000 or 30,000 to go back to making nothing again. That's a difficult, I mean, that is something that I don't really know that there's anything that prepares you for that. So I didn't intentionally take a gap year. It was just I needed a couple extra classes, but I worked a year between my first undergrad and then PA school. And I was like, wow, this is nice. I'm not taking out more loans and I'm making pretty decent money. And then I go back to not working at all and taking out a whole bunch more loans. There really isn't anything that prepares you for that, but just be cognizant of that. So if you work and make, you know, 25, 30 plus $1,000 in that year, great, save it, but be prepared for not making anything again if you're full-fledged in med school, PA school, getting your NP, you know, genetics, whatever you choose to do.
Okay.
Yeah, I completely mimic that. I just think, you know, sometimes some professions look at your experience, and having extra experience and real world experience can show them that you're ready for it, because some people are so burnt out from undergrad that graduate school right away can be just too much. And it's also nice to mature a little bit. And I used it for me as, hey, guess what? I am more mature now. I have 3 years of work experience, and these are all the skills that I've built that I wouldn't have otherwise had. So I think you need to try to use it to your advantage, but you need to be smart about it.
I think that maturity is a big thing. I applied to 10 schools. I interviewed at 9, which meant my basic credentials were good, but I didn't get into any of them. And nobody could really tell me why. The only comment that we got that was, well, we should need some time in the real world, whatever that means. The difference was, after 6 years in the military, retook my MCATs, talk about going back to study. I upped every test score 4 points when I retook my MCATs, because I did this novel thing called I did study. But when I went back the second time, I got into every school I applied to. And every school I applied to, I got an interview and I got in. And I think it was the maturity. It was the being able to say, you know I interview differently. I was more comfortable in my own skin. I wasn't trying to like prove something. It was like, hey, I want to be a doctor. I'm going to be a damn good one. Do you want me or not?
Yeah. Yeah. Isn't it that the average age of a starting medical student now is like 24 or something like that? There's a lot of gap years that go on there, and sometimes it's more than it's certainly more than one. But so that's not unusual, but there's a lot of reasons to take one. All right, Dr. Wilson, this is a question for you. How does family medicine differ from other specialized professions? Pros and cons.
Well, I'm very pro family medicine. Family medicine, as you know, we do joke that we're the jack of all trades and master of none. But that's not really true, because we are the master of the whole person, and we are the master of their family. When I was in private practice, I had some families, I had 4 generations. I had some families that we had to watch the scheduling because I didn't need the exes showing up on the same day. And that's something that I think is somewhat unique to family medicine. You know, internal medicine, you'll get that for the ages 18 and up. Pediatrics, you can get that for newborns ages 16 to 18, but I've got cradle to grave. I can do the OB. I can get them before they're born. And that's something that's really cool about family medicine. In addition, because our training is so broad, you can tailor to what you want to do. Like I said, I've done private practice, I've done ER, I have done, and I've done my own inpatient. I mean, I've managed an ICU, I've done correctional health care. I'm now back doing primary care at the VA. It's all adults. I can turn around and decide to do dive medicine. I like to scuba dive. I've threatened to go pick up my scuba medicine certification. My husband's a pilot. You know, I can do aerospace medicine. I mean, I think that's the cool thing about family medicine is it's what do you want to do now? Do you want to work part-time? Do you want to work full-time? You want to be crazy and be a hospitalist at night? So those are the pros. The cons are you don't make as much money. And it can be longer hours. You have to be able to set boundaries, or it can kill you. because there's always another patient who wants to talk to you or needs some help or needs counseling or needs this or needs that, or you want to research this a little more. So you have to be able to set boundaries. And I think that's the data, and the fact that we're not paid what we're worth are probably the two biggest cons to it.
Okay, all right. All right, we've kind of worked through most of all of the student questions. There's been a couple specific answers to students who've asked questions. So take a look at it in the chat window to see if you had a question that got answered. I was gonna finish up with one last question. Considering your career path, identify one pro and one con. Okay, you kind of just took care of that a little bit with family medicine and primary care, Deb. So I'm going to move on to our other panelists. One big pro for what you do and one big con. Well, maybe it isn't that big, but one of each, please.
I can start. The big pro about my job, and Dr. Wilson, you may agree as well, is that relationship that you're able to build with the patient. We also see families, and so you get to know those patients very well, and we find that very fulfilling. And then the biggest con, I think, and we kind of mentioned this, is a lot of the administration and the insurance companies that make doing your job a little bit more difficult.
Bureaucracy. All right, what else we have?
I mean, mine's the same. The pro is, you know, the relationships you get to build with patients, the relationships you even get to build with other healthcare providers. I love the relationships I have with all the different departments here. But cons are getting prior authorization for genetic testing is very fun. The paperwork is very fun. And you always have political things within each institution that make your job a little harder than you feel like it should be. And people have differing ideas on what's most important, where the money should go. So, you know, you do the best you can. I think that's something you're going to get in every institution. But yeah, I think you just have to weigh that in what you're doing and where you work.
Okay. Carrie, you want to contribute anything there?
I couldn't agree more. So a lot of the patients that we see, even though we're in a specialty, we see these patients regularly. We fix one part of their body, we fix a shoulder, they're back for their knee, or they're back for their hip, or they're in with a family member. So you end up developing a long-term relationship with them. I will say, when I worked 2 years in primary care, and I couldn't agree more with Tricia and Dr. Wilson. The doctor my collaborative physician, he delivered babies. And so we would really see them newborn all the way to grave. And so I had families where it was a grandparent and the mom and the baby. And it was like, I almost felt like, didn't I just see you the other day? I did see you because you were with your family. So, but it was great to have those relationships. And actually, from my standpoint, a lot of those patients followed me wherever specialty I went. They followed me, or their orthopedic condition, or whatever it was. So that I couldn't say enough about the relationships that you develop. But I will say that probably the most frustrating is, I've mentioned it before, administration, and I would agree, insurance companies.
Okay, all right. So it's really interesting. I'm looking. We've got 4 panelists here, 4 panelists doing different aspects of healthcare, and yet you share so much, you know, in terms of what's good about your jobs, what issues you have, and all of them very similar in terms of the motivation, why you do what you do. And so that's something that really stood out to me as I was listening to all of you today. Are there any final questions from our students? You don't have to have a final question. That's okay. But if you have one, if you have a specific question for one of our panelists, type in the chat box, or you could even unmute yourself at this point and ask a question. That would be fine. And something, okay. Okay, this is an interesting question. Do you need to be able to survive on very small amounts of sleep to be successful? That's a great question. All right, who wants to tackle that?
I don't know about the NPs and the PAs, but yeah, unfortunately in residency you do. Now the good news is, you guys, I'm a dinosaur. I went to medical school when medical students took call with the residents, and if they were up all night, we were up all night. That does not happen nearly the way it used to for med students. Even residency now, there's restrictions on work hours, X number of hours in the hospital continuous, and stuff like that. Now, that 24 hours you're allowed to be in the hospital can be 24 hours where you're lucky if you got time to pee, let alone anything else. But, you know, do you have to? Not yes and no. I mean, you learn. You know, and even like last night, for whatever reason, last night I couldn't sleep. So I worked all day a day on 3 hours. Had a lot of caffeine, but worked on 3 hours. And I'll crash tonight and do, you know, be up and going again tomorrow morning. You do have to learn how to pace yourself. You do, I think, have to learn how to be able to think tired, and depending on the medical specialty you go into, it may be more often than not. I mean, I've done ER, and I always did night shift in the ER. And, you know, I've got to be able to think at 3 a.m. just as much as I think at 3 p.m.
Okay, all right.
I agree with that. And I, you know, there's things that we do in life as well that take our time and energy and lack of sleep, i.e. children. And so I think it's just a matter, again, of that balance and how much you want to put into your profession. It sounds like most of us, not only do we do what we do, but there's other things that we do, whether it's volunteering or continuing our education. Like right now I'm in a nutritional outreach fellowship, not because I had to, but because I want to be able to provide my patients with more information on nutrition or healthy aging or diabetes. And so I think it's a matter of how much you put into your profession and how much you want to, you know, for instance, if you're in primary care, do you want to do endometrial biopsies in the office? So you educate yourself on that. Do you want to cover, you know, from OB all the way to geriatrics? It just depends on how much you kind of dive into your career.
I agree.
Okay, all right. And the last question that we had is actually something I was going to ask also, and some of our panelists have already been able to respond, is that would be able to get your emails if we ever have additional questions in the future. So if you want to just put something, if you're willing to share it, go ahead and put it in the chat. And while that's happening, I'd like to thank each of you for sharing time with us today and volunteering to come and speak with our students. We are recording this, so it will be made available at some point once we've figured out to make sure that we're doing everything according to Miami's rules. But I hope that everyone here has gotten something of value from this. I know I have, and I hope everyone then has a great evening. Again, thanks to the panelists. Everybody, stay safe, take care, wash your hands, don't touch your face, and wear your masks and social distance. And I have nothing else. Okay, so thanks again. And I see we have a lot of thank yous. The recording you'll just have to contact Tylen. She'll be able to figure out how she's going to put that forward. My guess is it's going to get posted into Canvas, but she'll have the answer on that. And boy, lots of thank yous coming in, people. So panelists, thanks again. This has been good.
Thank you.
Yeah, thank you.
All right. And Deb, I'll see you on Saturday.
I was just going to say, Joe, I guess we're talking 11 o'clock